Welcome to our presentation of our new Urgency of Normal Advocacy Toolkit. This toolkit was developed by 14 of the nation's leading scientists in pediatric infectious disease, emergency doctors, and pediatric mental health experts. It's a coalition of doctors who came together in pursuit of a common goal. Everybody here is very, very heartfelt and sincere in wanting to restore our nation's children after 22 long months of unprecedented disruption and despair. My name is Natalia Marukfer. I'm here as a parent of 2 girls, and I'm also a child advocate. I really believe that in order to restore my own children, we have to look beyond our own backyard and to our community and our nation at large and look out for all children at once. I am deeply grateful to everyone who collaborated here, and it's so heartening to see the brightest minds and really incredible research that we've been relying on for all this time. I'm especially grateful to Dr. Tracy Hogue for helping to bring this amazing panel together, and for Dr. Scott Balsidis, who developed this really just a unique and much needed toolkit that's going to help students and parents, teachers, administrators, and really anyone who works with children and wants to take the best possible care of our children and our school communities. Thank you so much for being here. We are going to do a Q&A at the end. Please submit any questions you have via the chat, and the presenters will see them at the end, and we will select a handful of questions and answer them. And so now I'm going to turn this over to Dr. Scott Balsidis.
Hello, everyone. I just want to start out by saying thank you so much for taking the time to be here and set the tone a little bit for this presentation tonight. First of all, I think should go without saying, but I'm going to say it anyway, that everybody here, I think, is here because we really care about figuring out what's best for our kids, both individually and collectively. And I think, one of the things that we really want to encourage for folks that might want to use this toolkit is that you take that same attitude out in using this in conversations with other folks. I know a lot of us have been through a lot. There's been a lot of frustration with COVID, I think, for all of us. We want to emphasize the importance of just compassion and understanding for whoever you might be talking to as we have these conversations around COVID, because we really do all care for our children. And if we disagree, it's because we're struggling to find the best path forward. And what we want to do with this toolkit is really empower people with information that hopefully can kind of draw us a little bit further apart, a little bit more close together on a shared understanding, and help us find paths forward that I think will be really beneficial. I want to also just mention, what the goal of this toolkit is to kind of put data together in one place in a form that's understandable for just about anybody. What I've found is I've tried to help people in my life understand what's going on in the pandemic, is that there's every day, dozens of articles written about COVID, and it's very hard to put all the pieces together and understand what the big themes are sometimes, especially acknowledging that although, we're here and we're going to use our expertise to speak, throughout the pandemic, there have always been disagreeing expert voices, and we acknowledge that. So our goal here is not just to tell you as experts what's true, but really to empower you with the ability to understand it yourself and take that back to your own community. So there's a couple things that we do in this toolkit to really kind of acknowledge that. Hey, you might not know who we are. You might not have reason to trust us. We want to make it easy for you to double check what we're doing and see whether or not you agree. So we've got a couple of quotes in here from other notable scientists, really giving similar messages to the messages that we're giving here, so that you can hopefully get some comfort that there's a broad number of people, not just the authors here, having very similar thoughts about COVID in children right now. The other thing that we've done is very much made sure to reference and cite every single thing that we say, so that anybody who wants to double check what we're saying, critique it, give us feedback about how we use the data, that's there for you. because really we do believe in being data-driven and using the highest quality evidence that we possibly can and finding the best path forward for our kids. So along those lines, I'm going to start first with this quote. Some of you may know of the former CDC Director Tom Frieden, and this is a quote that he posted to his Twitter account just a few weeks ago, noting the importance of shifting how we think about COVID from where we were in March of 2020 to where we are now. And that's really the theme that we're going to be kind of coming back to throughout this presentation, is that as the reality we're living in has changed really quite dramatically, our response to that reality can change and adapt as well, and that making sure we don't get stuck in a March of 2020 mindset. I just want to take a moment to thank all the co-authors who were involved in this. I obviously won't read all of this, but we did. It's really a pleasure to work with this group. We did make an effort to make sure to include folks with a broad variety of perspectives, looking at the different angles that we're talking about here throughout this deck. I myself am a viral immunologist. We also have the rest are all practicing physicians, including physicians with focuses on mental health, on infectious disease, on COVID epidemiology, emergency room care, ICU care. 8 pediatricians that are co-authors here, with again a wide variety of specialties, including pediatric mental health, as well as caring for those that are highly vulnerable to COVID infection, pediatric critical care, and then looking at physical, mental, emotional well-being of students. So we've tried to bring all of that together here into this toolkit to have all of those perspectives represented, because the main theme that you're going to hear from us tonight is that we need to shift from thinking about COVID as the #1 thing and at all costs to thinking about our children's whole person health and whole person well-being in order to achieve the best outcomes for those kids. One last slide of intro. Really, again, what we want to do is empower you, whether you're a parent or a student or a teacher or a school administrator. Everybody's making decisions about COVID right now. And the goal of this toolkit is to put the power in your hands so that you can understand better and feel more confident making the decisions that you have to make. We do focus a bit here on highly vaccinated communities. That is mostly because that's where in the United States, school mitigations happen to also be the strongest. It tends to be the places that are most safe from COVID right now that are also using the most disruptive mitigations. And that's one of the things that I think we want to speak to tonight. Again, the importance of compassion and mutual respect cannot be overstated. So I'll say it again right here. And then we also want to say that we're making recommendations here, but we don't believe that scientists should have the power to control everyone's decisions, that we believe that individual experience is so varied, individual risk for both mental, emotional, and COVID reasons is so diverse right now that we really are advocating for the decision power to come into your hands. So moving into the toolkit, this is our introductory summary. And as I said, things are very different from March 2020. At this point, COVID poses very little threat of serious disease for students, particularly in highly vaccinated communities. COVID has never been more than a flu-like risk for unvaccinated children, so we don't think extraordinary measures in schools are justified. Vaccinated children, fortunately, continue to be extremely well protected, such that they have almost no risk of serious disease, and Omicron doesn't change this. We can also protect not just the students, but the other members of our school community with vaccination, particularly with the use of boosters in those that are at higher risk. And that because of that, as we've been able to bring the COVID risk down, or we have the tools to bring COVID risk down, should we choose to use them, that we need to start thinking about the other things that are affecting our students, particularly their mental, social, and emotional health. The data that we're seeing is that children are experiencing massive levels of anxiety, depression, and other mental health impacts. And it's important to note that mental health is not something we can just ignore. The consequences of poor mental health can be severe and can even be fatal. And in that regard, we are very concerned about doing things that worsen mental health risk when in fact, suicide deaths for children in the United States vastly outnumber those from COVID deaths. Now, I want to be clear here that that doesn't mean we shouldn't care about any pediatric death. every child death is a tragedy, and we should do everything we can to combat all of them. And that's why it's so important to take a whole person look at how our kids are doing and make sure we're tailoring our approaches to what individual children or families might need. It's also really critical to not forget the vulnerable. There are some people out there who remain highly vulnerable to COVID, particularly people with profound immunocompromise or other major pre-existing conditions. And that as we try to balance all of the things going on here, we need to make sure that we have effective methods to protect those people and we're not just leaving them elevated risk. Putting these things together, we believe preserving in-person learning and de-escalating fear are the best responses to Omicron right now. We advocate against escalating COVID rules to prevent what are overwhelmingly mild COVID cases and can be better controlled by vaccination. And that it is important to normalize the daily school experience as much as possible. And that ultimately what this leads us to is that to protect our children as whole people, we need to make an urgent return to fully normal schooling with the passing of the Omicron. The first important point is that COVID poses a flu-like risk to unvaccinated children. This is very robustly established in data from the CDC as well as from other countries. I'm citing just the CDC data here. And here I'm just showing the data on mortality, although the comparisons are, again, very, very similar when you look at other things like hospitalization. And if you look at the graph on the right, right here in the sort of tan bar on the top, this is the COVID mortality in the worst 12 months of the COVID pandemic for children in the United States in terms of pediatric deaths, which was just over 500 between December of 2020 to November of 2021. And comparing that to the CDC reported flu mortality for kids, what you can see is that COVID lies right in the middle. That's not to say that it's not a risk for children. That's why we do advocate for vaccinating children. We would rather have, again, no pediatric deaths, and we have for most children the power to achieve that. But it does mean that it's not an extraordinary risk. And I think that's an important point because right now I think there's a perception that children are at some sort of much higher level of risk from COVID than they are from other typical respiratory viruses. And the data just doesn't support that. Another important point is long COVID. I think this is something that looms large in a lot of people's minds. Long COVID is a real thing that does happen, but its incidence is much lower, I think, than has been reported in some uncontrolled studies. When we look at studies that do a proper comparison of post-infection symptoms after COVID and post-infection symptoms in children who had other non-COVID infections, what we consistently find is that they're similar. So again, it's COVID for children is similar to what we've seen with other viruses. Now, fortunately, we also have the ability to make that even much lower. What I'm showing here is comparisons of the hospitalization data. This is data that's derived from the Delta wave in England earlier or in the fall of last year. You'll see that I refer to UK data a few different times during this presentation. I just want to note why we use that data in particular, although we do also cite CDC data. But the UK data is put front and center here for two reasons. The first is that the UK was hit by both the Delta wave and the Omicron wave before we were. So they got some of the earliest data that really then played out later in the United States. The other is that because of the UK's centralized healthcare system, they have the ability to process some of the data and break it down in just the way that we want to see. That's a little easier than it is in the more sort of distributed United States healthcare system. So with that note, if you look on the right at the graph that we have here, this is what was seen during the Delta wave, broken down by both vaccination status as well as by age. And you can see what we've known throughout the pandemic is that age is the major risk factor for severe COVID. And that, with children, the number down here is already quite small. Vaccination, thankfully, protects all age groups, bringing those numbers down. And if you just focus on the right, remember this bar here with a 3.9, that's a flu-like risk level in unvaccinated children. And you compare that to vaccinated children, where that bar becomes actually kind of difficult to see. This data comes from 930,000 total cases, including over 400,000 cases in children. What we can see is that in vaccinated children, there were 0 deaths and almost no hospitalizations. The vaccines are highly effective against severe disease. Fortunately, that remains true against Omicron. We have seen that the vaccines have lost most of their efficacy against mild disease because Omicron has so many mutations in the spike protein, and therefore we can expect to see many cases, as of course we are seeing globally at this point. But the critical thing is that efficacy against severe disease remains high, and on top of that, Omicron is less pathogenic. That means that cases will be overwhelmingly mild in children and in the vaccinated adults. Here I'm showing data again from the UK, both by age and by vaccination status for hospitalizations and for deaths. And first, I want to point out the big red bars. No one here is trying to say that COVID is trivial or that COVID was never more dangerous than the flu. It is abundantly clear that COVID in unvaccinated adults is far more dangerous than any of the respiratory viruses that we have grown up with. That's one of the reasons why we strongly promote vaccination, as well as the use of boosters in appropriate populations. But that doesn't mean the risk is the same in everyone, and it very much changes, again, by age and vaccination status. And what you see here is the exact same pattern when we talk about severe disease that we saw during the Delta wave. So it's the unvaccinated and the elderly that are at highest risk. And in vaccinated people under age 60, Omicron deaths are extremely rare or absent. And importantly, 2 doses of vaccine in children is sufficient to achieve the protection that you're showing here, moving from this small red bar to the very small blue bar. Now, you might be in an older age group or have someone that you care deeply about who's in one of these older age groups, and notice that even with vaccination, some of these blue bars are concerning. So I want to speak about boosters. We don't want to just make sure the kids are okay. We want to make sure everyone in our community is okay. And that's where boosters can play a really important role. For that remaining risk we saw in the previous slide, that's driven by a substantial decline in vaccine efficacy against severe Omicron in older folks who have gotten only 2 doses of vaccine. Now, fortunately, there's good data that has come out now from the UK, but also from the CDC, showing that giving a booster dose restores the vaccine effectiveness against hospitalization back up to the levels that we saw before Omicron. So back up to, we're talking about 90% efficacy here. And you can see that in the graphic right. We go from about 55% vaccine efficacy with only 2 doses to about 90%. So if there's someone in your life that might be in these higher risk group who hasn't gotten boosted yet, by all means, please encourage them to do so. Importantly, so far, that protection appears durable for as long as we've been able to monitor, given the relative newness of Omicron right now in the world. Okay, so at this point, I'm going to stop there, and I'm going to hand this off to Dr. Corey Stotsberry, who is going to speak about pediatric mental health.
Great. Thanks a lot, Scott. And thank you, everybody that's been able to attend tonight and for the opportunity to have a conversation about this stuff and to hear our information and hopefully to share ideas that you may have and questions so that we all can just keep this movement going in a direction of really trying to figure out something that none of us have ever dealt with and the opportunities we might have to help people. And so obviously tonight we're trying to talk about the ways that we can prioritize that towards kids. And it's interesting to be doing that at, January 2022. It reminds me about, somewhere in this time of year, it might've been a little bit later, but when things really got bad, and I just remember seeing the images coming out of Italy and then Manhattan and just things that we had never seen in our world. Things that maybe were left for places in the past or other places that weren't America. It was just very jarring. And I remember texting my wife and saying, like, this actually could be going in a direction where we need to prepare for me to be like old school living in the hospital and doing 24-hour rounds and that kind of stuff like they were doing, even as a psychiatrist. And that might be just how impactful this could be. And, I work in both inpatient and outpatient levels of care. And so after things got bad, the fallback was to start to think about, okay, well, let's sit back and see where this is going to go. And I remember that, drifting into summer of 2020. And that's when it really started from a mental health perspective. Obviously, this is just what I saw anecdotally, but the response was like, oh no, this is really bad. And worrying about where I was seeing kids going and just the presentations and the qualities of that I had never seen before in my career. And as a provider, sometimes we have varying levels of how we interact with our peers and have opportunities to check in with people. And it can be kind of isolating sometimes. And I remember feeling like I didn't really have an understanding of what other people were going through. Maybe it was just me. Maybe I was, making too big a deal of it or thinking that it was worse than it was. And I started to have these conversations with people, and many of the people that I've ended up forming the friendships that we're doing what we're doing together today. And everybody was having the same thing. And there was this moment where we all were talking about like, wow, this is the mental health side of things was actually quite bad. And the hard part about psychology, psychiatry is that the research collection or the data collection can be really hard. And sometimes it takes a very long time. I mean, we're even still waiting to get 2021 numbers back. And so we were just trying to look at how that went. And now what we're talking about today is just an opportunity to maybe put into context some of the information that's coming out and how we can now put that into the total package of the risk that we're seeing for people when we make decisions about the things that we can do for kids, for ourselves, and things like that. And some of that is being back-ended because now that we're seeing data about the decrease in the risk that's at hand medically in some demographics, now we maybe can be talking more concretely about where it is for the mental health risks. And so here we are seeing that some of the data coming back about the indicators for student mental health and distress being so high. Certainly you're seeing depression and anxiety doubling in the studies that we're referencing coming from both the Surgeon General and then the references that he offers in the CDC data sets that they provide. And that mirrors what we're seeing in public. 25% of the youth are experiencing an increase in depressive symptoms and 20% with anxiety symptoms. And then a study also showing that eating disorder hospitalizations had a 120% increase. You fold in the significance of eating disorders just with the higher level of risk that occurs, especially in anorexia, for just frank death, because the disorder itself is life-threatening in the malnutrition that it can have. Even when we have all our resources about us and all the hospital availability and all the providers that we had, not to say that we had the best support in general already before this stuff was happening, but we're now already taxing a system that was really trying to struggle to meet the needs of everybody going into 2020. And so that's where you see we have our statistic here that there were approximately 2,200 child suicides. That as another example where if anybody has the toolkit from the earlier publication, somebody, eagle-eye statistician out there gave us some information that we might have a more accurate number than what was offered in the publication by the CDC. And so we updated that. So again, it's not, as Scott was saying, it's not for us to really sit down and go, okay, well, this death is worth that much and that death is worth this much, and which one do we pick the most? But just the frank observation about where things are happening and what's going on, and where in some cases, and these are always hard to prove causation, but where we may be seeing certain mitigation strategies increasing the mental health drain on people or taxing the mental health system in terms of its ability to support people. Again, very difficult to show concretely that something is definitively happening, but when we start to fold in all the layers of considerations, this is one that needs to be part of the conversation. So there you have emergency department visits were increasing by 51% in adolescent girls for suspected suicide attempts, which is absolutely what I saw in my outpatient practice as well. Increased obesity and learning loss that we're going to be gathering the data on, not just the immediate incidence of how those things happen, but the confounding levels of that over time, or compounding levels of that over time. That again, as people sit down and try and decide where their risk-benefit analysis is on certain decisions for our society, these are all things that we're going to be folding into.
Hey, and thanks, Scott, and thanks, Natalia. And thank you everyone for joining us tonight. It's really overwhelmingly joyful to think that there are so many people out there who believe in our mission and who want to support us supporting you. Our goal is not to tell you what to do. Our goal as physicians and scientists with humility and compassion is to arm you with the tools that you need to help your kids thrive mentally and physically, and to meet their broad human needs beyond simply not getting COVID. As I've been talking about in this newsletter, I've been writing a COVID-19 newsletter since March 2020. Vulnerability means a lot of different things. In my world, seeing patients every day, I'm an internal medicine physician in Washington, DC. I see primary care patients. Vulnerability can mean different things. For one person, it's a vulnerability to COVID-19, like my patient I saw earlier this week who has COPD, is on oxygen. her vulnerability is to COVID-19 and other things because she has cardiovascular disease. Whereas my teenage patients, I see adolescents, their vulnerabilities when they've been vaccinated and some of them have been boosted, their vulnerability to COVID-19 is low. Their vulnerability and risk for, substance use and anxiety, social isolation, car accidents, those are those realities for that population or that person who's sitting in front of me. So the goal of this group is really to humbly recognize the diversity of vulnerabilities that we all have as human beings, to bring our clinical experience and our the fact that we've had our fingers on the pulse of the data, like a lot of you have, to you, to put everything in one place, and then to help you understand the framework that we're using to make decisions and to give you information you need to make your own decisions. In my world, again, as a practicing physician, it's really about balancing risk. So if I have a patient with dementia and diabetes and depression, I love alliteration, but I actually have a patient who with dementia, diabetes, and depression, we may tweak the antidepressive medicine and that exacerbates the dementia. And so, it's about threading the needle. It's about trying to mitigate harms and not trying to completely eliminate them, because of course we can't eliminate someone's dementia. We can't fully mop up, every pathology. And similarly with COVID-19, as you all know, the virus, even though we don't want it to be, will be endemic. It will be woven into the fabric of our everyday life. Not that we want it to, but we have to unfortunately accept the painful reality that we have this virus in our midst. It will have various waves as we move forward. And it's time now to think broadly about addressing mental and physical health in tandem. So it's specifically, as Scott and Corey said earlier, we are specifically want to make it clear that as we do in our day jobs as doctors, it's essential to protect the vulnerable. It's essential when we're talking about COVID-19 to protect people who are at particularly high risk for severe outcomes. So those are immunocompromised patients, patients with diabetes, patients with obesity, patients with certain neurological disorders. I think it's been made clear over the course of the last 22 months that there are certain patients and populations who are at particularly high risk for severe outcomes of COVID-19. And those are the people who really should get a booster shot. I think every adult should get a booster, but in particular, those are the people who stand to benefit the most from a booster shot. So for people who are at elevated risk, like my patient who had a liver transplant and is on heavy immunosuppressants, she is someone who I will recommend every time there's another surge of coronavirus. And I have recommended in the past during flu season that she wear a well-fitted mask, N95 respirator, because a properly fitted N95 mask is very effective at protecting the wearer, and it does not rely on the behaviors of others for protection. It should go without saying, but I'll say it again. We are believers in these vaccines. The vaccines are really, miracles of modern science. And if you are at high risk and if you are alive on the planet, we think you should get vaccinated because of the abundant real world safety and efficacy data on the primary vaccine series. So the first step, if you're vulnerable, and even if you're not vulnerable in particular, is to get vaccinated and boosted. And then I recommend to my high risk patients that during periods of high transmission, for example, maybe we'll have a surge next winter, limit your exposure to crowded indoor spaces. We know from abundant real world data that coronavirus, SARS-CoV-2 loves densely populated, poorly ventilated spaces. And so for my patients who are particularly high risk or who live with a particularly high risk family member, I'm going to recommend ongoing extra precautions. So avoiding crowded indoor spaces, the well-fitted N95 mask, test right away if you have any respiratory symptoms, and of course, seek attention from your primary medical provider. Right now we have a growing list of therapeutics to treat COVID-19. And of course, there's an urgency for scaling up the production of these antivirals, Paxlovid and Molnupiravir, to help really reduce the risk of severe disease in vaccinated patients and in unvaccinated patients. As we have said all along, this group and so many doctors, I don't know any doctor who doesn't think this way, we treat the vaccinated and unvaccinated the same. There's no distinction. It's our moral duty to treat everyone the same. And so again, the point I'm making here with this slide and right now is that just like we do with any other respiratory virus or really any other medical condition in particular, we try to take the broad data that we have about the condition. We have the patient in front of us or the population in front of us in the case of public health, and we focus our protection on the vulnerable. And one of the things that I think has been challenging for patients, for the general public and for my patients, is the fire hydrant of information coming out of the flow of information coming at us like water out of a fire hydrant for 22 months. And I think one of the things that we have not well communicated is the very different layers of risk or degrees of risk in certain populations. And that's exactly why we're here, to talk about the relatively low risk that COVID-19 poses to most children. That is a generalizing statement, but that is just a true statement compared to older patients with underlying conditions. And so again, focused protection is where we are now. When the virus is becoming endemic in parts of the country, we're seeing hospitalizations and case rates fall, not everywhere. And now it's time, in our opinion, to pivot to a more focused protection against COVID so that we can meet our broad human and health needs. So our recommendations for students' overall health and well-being is to keep school in session, to maintain in-person learning. I want to step back and just say, we recognize with great humility that there's wide variability and diversity in every school and every community, and that this may not be feasible in every community. But our hope and our goal, because of the benefit of in-person schooling for most children, is that we can impart the importance of that for their social emotional health and their overall learning, and to make every effort to have that happen, which I know if you're an educator or a school administrator on this call, you have done. Students' overall health is best supported by keeping them in daycare, keeping them in preschool, and keeping the doors of the school open. It's where children thrive, it's where they learn, it's where they connect with their peers, their coaches, their teachers, and it's where teachers, I have many patients who are teachers, it's where so many of them miss seeing the smiles on their pupils' faces and seeing a child connect the dots between a concept or make the connection and learn how to read in front of their eyes. The other thing we need to do, and I've been working on this with my patients and in my communications and my newsletter, is to help people understand just how normal it is to be afraid. And talking to someone about being afraid, it's not meant to diminish the importance of that feeling. Is to acknowledge and honor our humanity. In fact, if you aren't a little bit undone by the pandemic, I would be wondering what's going on, because this has been such an extraordinarily traumatic time for all of us in different ways. Whether you've lost a loved one or you've lost your fourth grade experience, we've all experienced loss. We've all experienced some level of anxiety and disruption. So it's important as we talk to children to talk openly about how they feel and how they might feel ambivalence, how we as adults are going to feel ambivalence as we transition and make changes into what's called a new normal and hopefully a better normal. It's important to tell the kids exactly how well the vaccines work. Unfortunately, in our public health communications, I feel that we've undersold the vaccines and how wonderfully effective they are. I think because Omicron is so widespread and because it's infecting so many vaccinated people, a lot of people are saying, well, the vaccines don't work. Remember, the vaccines are not impenetrable force fields. They do not prevent infection, but they take, as our friend Monica, who's giving a talk right now to her school community, Monica Gandhi, who's one of our co-authors, as Monica says, the vaccines take the fangs away from coronavirus and help turn it into a more manageable disease. So it's really important to tell kids who are reticent when they're able to and want to take their mask off, to explain to them just how well their vaccine protects them, and not to be afraid of a cold or a sniffle or a sore throat, because that is basically the kind of risk that we faced every day when we walked into school pre-2020. And we want to make sure that booster shots are encouraged and vaccination information is distributed equitably and honestly, and that we are reaching communities in particular where the vaccination rates are low. I think we need targeted interventions to reach communities that just need more information to make hard decisions about their children's health. And I think what we also want to do is avoid escalating mask rules and other COVID policies. When we restrict children, when we tell them that they can't see their friends, say at lunchtime, they have to separate by 6 feet. When we tell them they can't take their masks off outside, even though we know the risk of outdoor transmission is practically zero, we are enabling a narrative that school isn't safe or that they are vectors of disease, which, of course, kids can get COVID, kids can transmit COVID, but they're actually transmitting it in general less than adults do. And we shouldn't convey the message to children that they are posing harm to others. We want to make the rules and mitigation measures in proportion to the actual level of risk and not enable, as I said earlier, a narrative that the school is intrinsically unsafe. We obviously don't want to treat vaccinated and unvaccinated children differently. Children are not a danger. They are not vectors of disease. They are children. We want to encourage extracurricular activities and social events without fear. Childhood, I don't need to say this, but I'll say it anyway. Childhood is where we form the strong bonds for the rest of our lives. And those social emotional connections are really crucial. In fact, one of the reasons why I'm so interested in children, in addition to the fact that I'm a mother and that I see adolescents as patients, is because my adult patients who suffer from various diseases, from obesity to diabetes to cardiovascular disease, so many of my patients, in fact, I would argue all of my patients, the roots of their habits and their thoughts are from childhood. And so many of my patients who have experienced adverse childhood events have adult manifestations of those adverse childhood events, from their relationship with alcohol, their relationship with food, and the way they manage stress. So the more we can allow children to have normalcy at school, regular social time at lunch, and ultimately unmask them, and we can talk about that shortly, the more we can allow them to nurture their physical selves and their mental selves and allow them to learn in an unrestricted, normal way. And just in conclusion, I think just to frame this again, as I said earlier, as Scott and Corey so eloquently said, it's really time to recognize that health is about more than the absence of COVID-19. No one wants to get COVID. I don't want to get COVID. I actually can't believe I haven't had COVID yet. I've been seeing patients for 22 months in person. No one wants to get COVID. We want to protect ourselves from it because of the risks for long COVID, because of the risks for being sick and for transmitting it to other people. But we also need to recognize that health is about myriad other vulnerabilities that we face in our everyday life. And it's time to balance the harms of COVID-19 against the harms of the restrictions themselves. COVID is here to stay. We don't want it to be. We can only mitigate the risk. We cannot eliminate it. And it's time to help our children bring a level of normalcy, and again, a better normal, ideally, to their lives. And I appreciate the time you've given me, and I'll hand this over next to...
Thank you guys very much. Lucy, thank you so much. I think that was just a wonderful overview, very specifically continuing the themes of what we're attempting to do here. By way of introduction, my name is Jeffrey Gallis. I'm a pediatrician and a pediatric cardiologist in Charlottesville, Virginia. I have been very active in the whole COVID mitigation strategy since kind of day one, mainly helping summer camps, schools, and congregate care settings since basically the fall of 2020. We've been very successful in publishing some of our work and how we've been able to mitigate spread. We've been at the forefront of being able to advocate for children to be able to safely move through a pandemic. And much more importantly, I think we've been very important in empowering all schools, childcare settings, to know that they are some of the safest places for our children, both from a COVID perspective as well as from a non-COVID perspective. I also, though, am going to take on the task of talking to you about some of the data surrounding masking. Now, I want to be very, very clear. There's been no mitigation strategy that we have used that has symbolized the pandemic more than a mask. And it is because of this that we as authors have kind of spent countless hours making sure that we can attempt to get the language surrounding these recommendations to be as truthful, as clear, and probably as most importantly, as respectful as we possibly can. But make no mistake, we know we're not going to be perfect. And our hope for everyone here is to continue to review this section of the toolkit. And again, as it spurs you to begin having these conversations in your own communities. We know that masking is part the science that we're going to show, and also understanding how it fits within the construct of the institution, how it fits within the operationalizing of the environment, and much more importantly, of how we deal with people's emotional and mental health surrounding this. We ask you at this point to use these words that we're going to go over and be very respectful to each other about the fear surrounding taking off masking, about the fear surrounding putting on a mask, and continue to show kindness as we begin to move past this strategy as it exists specifically in the pandemic. I want to reiterate these words, and I'm going to reiterate it over and over again, that we don't exactly have the right answers on masking. But what we can do is be cognizant and resourceful, understanding the data, but much more importantly, be respectful of everybody's opinions and everybody's worldview when it comes to this strategy. I assure you that I, along with everyone, have evaluated the evidence through the exact same lens as we review other non-COVID public health strategies. We tried to take that very, very clearly to look very specifically at the data that we see this and apply the same rubrics and the same levels of evidence that we would do to any treatment strategy that any of us utilize. I have a master's degree in biostatistics and clinical research. And so you're going to see that I kind of take this from that standpoint very, very significantly. And many of us on this call have significant backgrounds in both academic research as well as writing. And the reason that that is such an important concept for me to make sure that everybody understands is that we want to have these open discussions, not these absolute discussions, but these very, very much open discussions about how we utilize masks and how we think that they fit within the framework of schools. Please note, we do not believe that masks don't work. I'm going to say that again. We do not believe that masks do not work. We have all used them actively in our clinical practices, whether it be in the clinics, many of us that are hospital-based, and also many of us that are ICU-based well before this pandemic, throughout this pandemic, and we are going to continue to use them through the pandemic. We very much understand their abilities to be used for source infection control, and we are going to keep understanding that they are very beneficial in how we use them for source infection control. But point of care source control of masking is not what we are discussing here today. What instead we are discussing is how effective they are in a real world use in a very specific environment. And that specific environment is schools and other childhood settings. This is a very, very different concept, and one that we want to be able to provide and empower everybody to understand the contextual relationship between how we understand a mask works to control spread and how effective it is when we talk about a real world use. This is a very basic public health principle that many of us have to embrace every day in our practice. We can utilize tools to try and do everything we can to keep kids safe and to keep our patients safe, but we also know that there is a very real world aspect to how we utilize those tools to make sure that they actually are being effective when we study them in real life patients. Scott, if you go to the next slide, that'd be great. Early on in the pandemic, when we learned about the airborne nature and pre-symptomatic transmission, it made very, very logical sense for us to employ masks with a very, very broad brush. All of us supported this in our own communities. I supported it very extensively in all of the schools that we utilized. And yet we were not confident in those early months how that would affect children. That was the reason that we were so confident in that we had to do everything we possibly could to mitigate the spread. We had a very, very low population immunity, and we were a little uncertain exactly how this disease was going to affect kids of all ages, not just necessarily young children. But now, as my colleagues have explained, population immunity is not low. Our knowledge of how this disease affects children has grown exponentially. Our use of therapeutics has grown exponentially, and our vaccination has been able to grow exponentially. This implores us to evaluate whether or not we are still seeing that same benefit. This first slide is looking at some of the government studies that utilize what's called a control group. Now, what a control group means is that we want to be able to look at a group that was masked in addition to a group that was not masked. The CDC study is the top one from Georgia that looked at this and found that there was a modest reduction in this. The UK study also found a very modest reduction when they looked at the controlled group environments. I want to draw attention, however, to two specific data elements with this. The first is that neither of these results were deemed what we would call statistically significant. In kind of layman speech, that means that we cannot necessarily assume that the result was just due to chance alone. In all other treatment studies that I utilize as a cardiologist, as a pediatrician, we have to try to understand what the strength of the evidence that we see when we look at an intrinsic and concrete data point. With this would not hold up, and I would not be advocating if this was a different type of treatment protocol that the level of data would suggest that there was a significant effect. This is not to say that these weren't important studies. This is not to say that these weren't well done studies, but the results and the aspect that they found was overall not very strong in suggesting that we were seeing a very, very significant effect. In the academic world, so this is not in government studies, but this is more in peer-reviewed literature, we have found very, very similar results. Now, these studies are done by very reputable authors. These are people that have significant research backgrounds and have published extensively before COVID on various other topics. So in the academic world, we've seen from Florida, New York, Massachusetts, and Wisconsin that we have not found what's called a strong association between broad use of masks in school and the incidence of COVID-19 in those schools. Again, that does not mean that we don't understand the cause at this point. We just don't have a predominance of evidence in the same way that we look at for all of our drug studies, for all of our other clinical therapeutic studies that we use outside of COVID, to suggest that we see an association between those schools that utilize masking extensively and the schools that didn't. There was a very well-controlled study then that was done from Spain. And in these groups of children that wore masks in school, had the same rates of transmission as the children who do not wear a mask in a very, very similar age range. This was in the 4 to 5 versus 6 to 7-year-olds. Again, we are lucky in some degree that we have some other controlled studies throughout other countries that utilize masking very differently in order to give contextual framework to how we utilize it in our own classrooms. So these are some of the more common off-cited studies that we talk about when we look in some of the lay literature. Again, I'm not going to suggest that these are poorly done studies. I want that to be very, very clear. But one of the things that it's important that we teach a lot of our resident trainees and our fellow trainees when they're going through this is how to understand the data that is being reported out of a paper and how to understand the strength of that finding as it relates to making a change in your clinical practice. So how effective, what these are trying to look at is how effective are masks in a real world school environment. And I would posit, and a lot of the colleagues would posit, that these studies were not designed to answer that specific question. They were designed to answer slightly different questions, but the question that we want to know is how effective are masks in that real world environment. Some, like in the Massachusetts study, had universal masking without a control group. And so we can't draw a conclusion about how effective masking was if everybody did it. The other one, which is an Arizona study that is very frequently talked about, was again a well-done study from the standpoint of what it was trying to look at. However, the problem is that they were not able to isolate the mask concept. They were not able to isolate it from the degree and level of vaccination that we otherwise had seen throughout that area. What that means is that we can't unlink vaccination rates and mask rates in the Arizona study. While it means that we can take obviously other ways in order to try and figure that out from the data that they provided, we can't learn anything about the effects of school mask mandates from this study. The authors of this one and the cross-sectional study below it owned up to this very, very specifically in their conclusions, that while they cannot assign causation, and they cannot say whether or not we actually think the masks were the one thing that had an effect. What they can do is say that they noticed a difference, and that difference was probably, in their own words, correlated with a lot of other things that were going on in those various districts at the time. It's just not something that they were able to otherwise demonstrate. It's very important at this point to remember that most of the Western world does not use masks in schools. That's especially true in elementary schools. We are one of really only a few countries that has chosen to utilize this as a predominant mitigation strategy in schools. It allows us to have somewhat good control groups in order what we can do is to really study our own country. Despite highly variable masking strategies, schools across the world and the country have continued to demonstrate the same low in-school transmission, even with the Omicron variant, which calls into question a little bit how effective these strategies truly are at the public health level. Again, there is no doubt, absolutely no doubt, that they are effective at the source control level. The questions that we are looking to the studies to answer, but they are not really able to do that, is how effective they are at the public health level. It is really essential that us as pediatricians, that we always care for the vulnerable and the at-risk patient. Dr. McBride talked about that extensively, and it is something that we in pediatrics incredibly take to heart the same way that even adult physicians do as well. We strongly, strongly advocate for these children and family members to have critical conversations surrounding using respirator masks when appropriate against COVID and other viral pathogens if they are deemed at risk. Many of us on this call are pediatricians that care for highly at-risk populations. And we are having these conversations every day with our patients that truly are at risk. But conversely, the universal push towards using respirator masks cannot be applied to children. Fit is incredibly important to achieve effective filtration. I think anybody that otherwise understands how, or anybody that has worked in a hospital setting understands how we have to go through fit testing, or really in any OSHA setting, understands how we have to go through fit testing to make sense. We are much far better off, as we have argued, from a resource perspective, to focus our energies on utilizing maskings for at-risk populations, rather than somewhat of a watered-down masking approach for all children that we're just not 100% convinced is backed by the data. Our summary takes this exact same approach as we apply it to other consensus and guideline papers in our respective fields. Many of us have written consensus and guideline papers in our own individual subspecialties. And when you do that, we have to look at levels of evidence and degrees of consensus in order to say how strong we think a recommendation is. With our school masking summary, we want to make sure that we understand that we took the same level and the same degree and the same processes that we would do if we were writing as a guideline paper for any other field. Widespread student masking has just not had a scientifically established benefit in real world settings. Again, not looking at source control in individual use settings, in real world settings. And we should be comfortable no longer recommending it. We also, though, however, very much understand that the problem with this information is that we have to understand that it takes some time for schools to be able to change their policies on this. And so we think it is reasonable to start thinking about this in the middle of February, the end of February. We're through this current surge. Everybody can start to think about a little bit of what it looks like to remove a mitigation strategy that we've held on to for so long, but much more importantly, to be able to support people that know that it's not going to be something that's easy for us to be able to completely transition from. While we do not know the effects of masking long-term, and it would be all completely speculative to say that we know that, we do know that normal child development must be factored in when recommending a mitigation strategy. Emotional cues, language and reading development, and normal socialization in children is incredibly important, vitally important for their overall health, not just their COVID-free health. And so we cannot minimize the effect that we see with those specific pieces. And so while I cannot tell you that we have good data, because we do not, on potential harms for long-term masking, we know that it's poorly understood, and we most certainly know that we at least have to be thinking about the consequences of what long-term masking could do to a child. We are not saying that in times of critical need that this is important. We are not saying that this is a tool that shouldn't be able to be utilized by individual situations at times of critical need. But using this at this time is not defined as a time of critical need when it comes to the health of our children. Moving to mask optional policies is part of normalizing school for children. And many of us that have been extremely active in setting up COVID mitigation strategies across the country in children and congregate care settings, and almost all the authors have done that, have realized that it is a reasonable time to move in this direction when most regions will be through Omicron surge and better prepared to move forward. Again, I thank you guys very, very much for your time. Before I hand it back to Natalia, I want to reiterate that we want this to be utilized and empowered for people to be able to have conversations within their own communities, to be able to look at the data concretely, to be able to understand its strengths as well as its limitations, and answering the questions that we wanted to answer. We are not saying that masks don't work. What we're questioning is how effective they are when we look at a real world school environment. Thank you guys very, very much.
So if we can have all the panelists just turn their camera on so that everybody can see us, and then we'll go to question and answers.
Can I ask Quadro this question?
Sure.
What counsel would you give? This is a great question. I get this question all the time from patients. What counsel would you give children who live with high risk patients? So children who live with high risk, parents, family members. And you know, you're an ICU doctor and see the sickest of sick. What are you recommending children who could potentially bring coronavirus home and to their high risk parents or family members?
Thanks for that, Lucy. First of all, I gotta really thank Scott, Natalia, Lucy, all of this for this setup, because I think it's having these the toolkit and this interaction is so valuable to so many. So I just want to thank you for allowing me to participate. You know, I think like anything else, Lucy, it comes down to what our own risk assessment is. And I think people need to, this is what our job is to really quantify as best we can what the risk is to that individual member or to their family. So, you know, I always say when it comes to individual risk, you know, ask yourself, what's the risk of you landing in ICU? What's the risk of personally you being hospitalized or dying from COVID? And with that risk, this is where we try and focus as much of our interventions as possible. Are you boosted? Are you have testing readily available so that if you are positive, that you could get therapeutics, whether that's the oral, the Pfizer or the Pfizer pill, Paxlovid, whether that's monoclonal antibodies, fluvoxamine, are those readily available for you? And then in terms of the kids, like what it comes down to, you're going to weigh risk, as Lucy mentioned before. You know, like safety is also, you know, the risk of transmitting COVID, but it's also their mental health, their physical health, their social well-being. And what we've just done is like have that conversation. Like in our house, for example, we have an immunocompromised caregiver and elderly parents. And I was in the throes of ICU in March, and we knew what our risks were. And we talked about it, and we collectively as a family said, we're going to try and live as close to a normal life as possible. We'll do our standard safety measures. We'll all get vaccinated. We'll wear masks in high risk areas. And this is what we accepted. And so to answer that as short as concise as possible, knowing what your risks are, knowing what's acceptable in your family, and know what tools are available for you to protect yourself.
Scott, I'm wondering if we could ask Tracy the next one regarding pediatric vaccination. Someone's asking, it seems perfectly poised for Tracy, given your part Dane. But pediatric vaccination, the US and Canada make a strong recommendation to vaccinate all eligible children, but Denmark and the UK do not recommend mass vaccination of healthy children 5 to 11. And there's been some concern in the chat that we're so pro-vaccine and leaning too heavily on the vaccine. And I just want to make clear that we believe in the vaccines, but we ultimately believe that the decision to vaccinate your child, to get a booster shot, you know, these should be nuanced discussions with your primary care doctor based on your unique risks. But Tracy, what do you make of the question about, you know, Denmark even going further to support natural infection instead of vaccination for healthy children? And what explains the inconsistent recommendations given these advanced nations that all have access to the same science?
Yeah, so thank you. So it's actually Norway and the UK that are recommending that. So Norway has basically come out and said that the risks to the children there have been so low that they are waiting for additional safety data on the vaccines before they would consider recommending vaccinating 5 to 11-year-olds. And there has been some talk of, that you may actually get better immune response as a young person. And that's why but I don't think that that's the overarching reason why they've decided to do it. I think it was more of they're not convinced that the benefits outweigh the risks with the current data. And really, I looked at the data last night, and they have one of the, if not the lowest mortality rate among children of all the countries in the world from COVID-19. So that, comes into play with their decision making, I think. But they've also said that it should be a decision made with pediatricians and physicians, and that if children are considered high risk, that they have access to those vaccines. And that's the same in the UK as well. And then I also got a question on boosters as well. And, I would start by saying the same thing applies, that it needs to be a discussion that families and children have with their pediatrician and their doctor about benefiting from booster vaccinations. But probably the best study that we have on boosters right now and the benefit against hospitalization is from Israel, which was published in the New England Journal of Medicine. And they didn't find significant benefit against hospitalization among people less than the age of 40. And that is actually consistent with the data that we're seeing at a population level out of Denmark. There, it might be closer to around 50. That there's a clear signal that people would benefit against hospitalization, but that's of course across a whole population, and there are certain individuals who would be much more likely to benefit from a booster dose of vaccination. So again, it really should be a discussion that's had between families and their pediatricians. And as long as I'm going and I'm rambling, I got a question about masks too, which was about our study that we're doing in North Dakota. And this is a study that hasn't been published yet, looking at 2 paired school districts in the same community, with about 12,000 students, one with a mask mandate and one with masks optional. And we had continued to see very similar rates of COVID-19 among the students in both of those districts all along. And they both had a surge with Omicron. And now last week, the mask mandate district did drop their mask mandate and went masks optional. And they actually came down a little bit closer to the low rate of the masks optional schools. So we really saw throughout the course of the fall that mask mandates did not have an impact on the case numbers within the schools within these 2 large districts. And so we're going to be submitting that for publication now, probably a month from now that there's been like a crossover with the one school dropping the mask mandate. To keep watching that for a while.
And so I'll go next to address one of the questions. There was a question about different countries, like why has a place like Japan or New Zealand sort of done better or worse relative to the US in terms of death rates per capita. The first thing I want to say is that there's a lot of differences there, right? That aren't necessarily super instructive. For example, New Zealand is an island. And they were able to completely control what was coming into the country for many, many months. So it's not really super useful necessarily for us here in the continental United States. I would say what we have seen consistently across the board, across all countries, is that the better the vaccination rate gets, particularly the adult vaccination rate, the better the outcomes are, when the next COVID wave comes around. And that's also true. You can break the same thing down even between counties within the United States. For example, my county here, San Mateo County, California, fortunately, is one of the best vaccinated places, in the country. And what we saw when the Delta wave came in was actually substantially fewer deaths than a typical flu season, which I say just as a way of kind of offering hope to everybody here. That it is possible to get to levels of immunity that get us there, because that was very, very different from the experience that we had in the winter surge, before the vaccines were really available, when what we saw was really, far, far more damaging than a typical flu season. And really the game changer there was vaccination.
I'm going to toss the next one over to Jean. So Jean Noble is our fearless physician at UCSF in charge of the COVID response team at UCSF's ER. So can you talk about how you would talk to a family who is worried about unmasking and what the risks, this is just a general question, what the risk would be within the family, at the school? Like, how can we say, the question is, how can we say with confidence that taking masks off are going to have more benefit? And how can we say with confidence that they're harmful? How are we making that judgment call? And as someone who's seeing patients every day, are you finding this a complicated question, or can you just talk a little bit about the masks in general?
Yeah, I think that, in this mask debate, we really lost the thread of how incredibly effective our vaccines are. So one of the things that I often bring up with people, with patients and their families, is that we all got vaccinated to get back to normal, to get back to pre-pandemic living. And our vaccines have been wildly effective in preventing serious illness and disease and death. And that's why we wanted them. Our masks were really most appropriate early on when we had very few tools in our toolkit. And we were doing the best we can, with a paucity of data. Now that we've had all this time, I explain to people that, we have used masks traditionally in medicine. We don't have a ton of data about it, but we've done it because, hasn't been a harm to that. And that's just not true when it comes to kids in schools. So what we worry about is that communication, reading of emotions, it's hard to do with masks. So as an emergency physician, I wear a mask, 8 hours a day. Every day I work in the emergency department. When I have a patient who is, very young or very old, or someone who is hearing impaired or speaks English as a second language, I frequently pull down my mask to communicate with them because they can't understand me. Our communication is really just, the quality of that communication is hindered. And that's a big deal when you're in a critical care and emergency situation. But I think that when you are in, a kid who is wearing a mask for many, many hours a day and learning to pronounce words correctly, learning to read, learning to interpret the emotional expressions on other kids' faces, on their teachers' faces, that's a big deal. So I try to emphasize vaccines are what really protects us. That is that is really the closest thing we have to a silver bullet here. And it's now the time to start thinking about the downsides of those masks.
And I think it's important to make it clear to people that when we are talking about lifting mask mandates, we're not talking about A, masks can't possibly work, or B, that you can't mask yourself if you're particularly vulnerable or if you just want to and you're not quite ready. Can you talk for a second, Jean, about the benefits of the one-way masking, the N95 masks, because it doesn't, you're kind of your own one-woman band if you're wearing a mask. You don't, okay, an N95, you don't have to rely on other people's behaviors. Is that right?
Yeah, and that's really the approach we need to take at this point. So not only is it not quite fair or efficacious to be masking large groups of young, healthy populations, we can accomplish the same thing. In fact, we can do it better if we really focus on the most vulnerable among us. So, slapping on KN95s of variable quality or non-fit tested N95s, to wide populations is probably not going to be very effective. They're really uncomfortable to wear. If you wear them for hours, they get wet, their filtration is compromised. What we really need to do is single out those people who are at highest risk and get them the best quality mask and really coach them on how to use it. So we did an N95 study at UCSF earlier on in this pandemic and found that the fit test, meaning when you wear an N95, it has to actually be fit to your face, and you aren't supposed to be able to smell or taste substances around that mask. That's called the fit test. That mask is good for you once you've passed that. We found that after many hours of wearing an N95 in a single donning and doffing, where you took it off and put it back on, about 30% of those N95s then failed. And this is in the healthcare setting. So they're not designed to be worn in daily life for many hours, taken off to, have a sip of water or to eat your lunch and put back on. They really are for targeted high-risk situations. And we could get the very best quality masks out to our most vulnerable people and really coach them on the importance in the settings, when to use those masks. It's not effective. It's not comfortable. It's really difficult, I think, to promote using these respirators on a wide scale, just, for all comers.
Jean, I would also add to that, we know that one-way masking works so well because it's what we all do in the hospital-based setting, right? So when we're all, those of us that are on this call, those of the authors that work as hospitalists or in critical care physicians, we don't put masks on the patients that we know have COVID. We walk into their rooms because we use a well-fitting respirator mask, and that does remarkable of keeping down and protecting the wearer, which is us. And so, I think that's understandable. But those are patients we know have COVID and are very sick and contagious with COVID, and we utilize masking that way and have profound effects at it. We know masking in that manner absolutely works.
That's exactly right. And that's that perfect targeted setting, a limited intervention, and in really taking care to wear the right high quality mask then, not as sort of a generalized practice to do in everyday living.
I have a question here about pediatric hospitalizations. Of course, any child death, any child hospitalization from whatever cause is something we want to prevent and do everything we can to mitigate against. Eliza, Dr. Holland, who's a pediatric hospitalist at UVA, I'm going to ask you this. What are you seeing on the ground at UVA in your hospital? What are you seeing? Who is sick? Who is in the hospital from COVID? What's happening on the ground?
So that's a great question. I just got off a week on service, and I will say that this week was the most COVID positive patients that I have had throughout the pandemic. We're definitely seeing more children come into the hospital who are COVID positive. Now, a big asterisk to that is, of those patients, I had 8 patients who were COVID positive or who were on restrictions. 2 of them were actually sick with their COVID. And the others were just all found incidentally. There was a patient who was there for suicidal intent who was COVID positive and had to stay with us for 10 days until she was technically free to go on to a psychiatric hospital. I had 2 babies who were born to COVID positive mothers, and they were staying in the hospital for reasons that were totally unrelated to their COVID. And a couple of patients, I had a cystic fibrosis patient who was having a CF exacerbation after his COVID infection 3 weeks ago, which I would totally expect with any viral illness. So again, out of those 8 COVID positive patients, there was only 1 who was really sick from her COVID, and 1 with a metabolic disorder who was going to come in with any fever, but looked great.
And are these vaccinated or unvaccinated?
My cystic fibrosis patient was vaccinated. I don't know that any of the others, well, obviously none of the others were. But again, the other ones who were in the hospital, there was a 6-year-old who was unvaccinated. Mom was waiting for the right time to get her vaccinated. She was the one who was sick but fever and vomiting, nothing that we don't see already in other pediatric viral illnesses. There was nothing out of line with what we saw with her. She was unvaccinated, and then obviously the babies were unvaccinated. The teenager on suicidal precautions was unvaccinated, but not sick at all from her COVID. So I was going to say, what we have seen far and away much more of throughout this pandemic is children coming in with severe eating disorders that require hospitalizations because their heart rates are so low that we're worried that they're going to have cardiac arrest at home if we don't start getting calories into them and get their electrolytes corrected. We went from about 1 every 2 months to 1 a week since the start of the pandemic. So that is what we consistently have on our pediatric service. We have a good number of drug overdoses, suicidal ideation, and then just the other random and assorted pediatric illnesses. I have definitely seen a couple of kids sick with Miss C, but the ones that I'm seeing on the pediatric floor get better with medications and go home. And I think, Jeff, you probably follow them up in your cardiac clinic. I think overall their outcomes are very good. We have had a couple of overweight teenagers who are unvaccinated come in very severely ill with COVID pneumonia that we've really had to work to get them through. But the vast majority of our pediatric patients with COVID have mild illness or really picked up just because they're coming in the hospital.
Lucy, could I just add some quick data on pediatric hospitalizations? Just from looking at data from seroprevalence data from worldwide, like who actually has COVID antibodies, children who got it. So most children will be asymptomatic. And so the actual chance of a child being hospitalized from COVID-19 is approximately 1 out of 500 to 1 in 1,000 infections, if you're infected. So if the child's infected, that would be on average their risk, 1 out of 500 to 1 out of 1,000. And now with Omicron, we're seeing that there may be close to a third of that severity. And so obviously there are still kids who continue to be at high risk, but I think that just puts it into perspective on average. And then I would just mention about Miss C that that has been going down. That actually decreased quite a bit per infection during the Delta wave, and we're still waiting, of course, for data on Miss C from Omicron because that's delayed when that shows up after the infection. And then all along, we'd really been seeing that about 40% of pediatric hospitalizations, even before vaccination, were incidental. So not caused by COVID, but the diagnosis was made when they were in the hospital. And that percentage would be expected to increase with the vaccinations of children, that we're going to be finding more and more of the cases that are reported as pediatric hospitalizations are actually just incidentally found while the child is there for another reason. So just some numbers to keep in mind about that.
And I just want to add on to Tracy's comment that at UCSF, for instance, we have seen up to 70% of the pediatric hospitalizations are actually just with COVID and not for COVID, as you would expect with Omicron.
And I know a lot of people, love to or have concerns about that's still a patient in a hospital bed, and that's still a burden of things. But when we talk, and that is very true. And I don't want to say that it's still not tiring to, care for any child that's hospitalized. But when we look at disease burden, that is a really important, distinction that we have to make, is that how much is COVID causing excessive disease burden? And we're not seeing that in our hospitals really across the country, that it's causing an excessive pediatric that is disease burden.
And I would like to just bring up one more point that came up in a discussion earlier today, and I'd be curious to hear from people in other areas of the country. But there was a mom who has a child with neuromuscular disease who's really concerned about that child getting COVID. And shockingly, our kids with neuromuscular disease and that lung disease that comes along with it are not the ones that we're seeing hospitalized with COVID. So their families are vaccinated. They're doing a really good job with that focused protection. What those kids are coming in with is rhinovirus, which is a cold virus that can cause really severe illness. And that is the one virus that has persisted at pretty much the same levels throughout all of our COVID mitigations.
There's a question here that I'm going to ask Corey about. Corey, who's our pediatric psychiatrist, what are you seeing in your practice as the manifestations of children in distress, whether they're depressed, anxious, having disordered eating? I mean, I think we can all agree that it's not the pandemic restrictions alone that are causing distress. I think we as a group have acknowledged that kids have enormous variability and diversity in their lived experiences. For some kids, the stress is because they lost a loved one to COVID-19 itself. For some kids, it's the masks. Every child has a different experience, but I'm interested in, as someone who's seeing kids directly talking about emotional health every day, what you're witnessing in real time.
Yeah, thank you. Obviously where to start and how long do you have, but the challenge, I mean, one thing to clearly identify, and this is kind of eye test stuff, just on kind of the pattern recognition you get with seeing patients all the time, is the average intensity of what they're dealing at this way is way up. So the the teen that might be coming in, and I'll talk about some not patient specifics, but just some very tough stuff. So if anybody has a hard time listening to this thing, just kind of a heads up. But thinking about being suicidal and just casually having what we call a passive wish to die, or if I didn't wake up tomorrow, I'd be okay with that, are really changing to I want to die. And I'm thinking about how to do that. And people not just saying, well, I might cut myself or I might overdose, but having formalized ways of getting to ropes and firearms. I mean, when we keep them at home, the access to firearms goes way up. That's just what happens. Now, can I say for sure that that's what's exactly occurring in any of the suicide numbers? Like, no. But these are just kind of things that when we're trained in the way to do our job, we start to think about. And I have a specialization in eating disorders, and one of the higher risk, most difficult groups of people that we'll come into are pediatric males with anorexia, because it's just very rare. And when it happens, for some reason, it's particularly intense. I maybe had been seeing those in my outpatient setting every 5 years or so. It just was pretty rare. I mean, honestly, they're going into UCSF and seeing them at the program. I've had 2 or 3, and that's not a big number. But for me, something that I didn't see very often is just rapidly increasing in how frequently that's happening. And then I think the other compounding part, and just what stuck out to me, I remember, like I was saying back in 2020 as well, the number of kids that I met that had no mental health history whatsoever leading into this. And then all of a sudden, here they were coming in with, I just don't want to do anything. I can't get out of bed to go do the Zoom class or whatever it might be. I'm staying up all night with anxiety, and the sleep dysregulation is all over the place. And then the other really significant thing that happened so I'm split kind of between California and New York in the work I do, the frequency at which I saw people get way better the second they went back and hung out with their friends. When I was working on the inpatient units, you'd meet people that were being admitted for having never had mental health history before, and all of a sudden being suicidal. And I'd go in to round on them, and they were great. It was 2 or 3 days in, and I wasn't sure exactly what it was. They had just spent 72 hours hanging out with other kids, one-on-one all day long. And at that point, we weren't masking them in the units because that just wasn't a recommendation back then. So they had normal life, be it on a unit. And similarly, when kids were going back to school and hanging out with their friends and getting to do stuff, the dramatic improvement. So I think that was another area where I just saw that, the role of interpersonal connection, the relationship with parents, and the way that all of our emotions and stresses being frayed right now, and the intensity of all that was just bringing the net morale down. And I hope that when we turn this around, we can really see that improve.
That's great. I'm going to shoot the next one over to Quadro. How do advocates like yourselves help unravel the political influence from science? Quadro, if you could just solve that problem right now, that'd be really, really handy. Is this something new, or has it always existed and we didn't notice? It seems that now even our own doctors are seemingly unwilling to deviate from any of the government recommendations and apply an individualized approach to medicine and mitigation. Man, I'm putting on my, can't wait to hear your answer.
Yeah, I'll this is a heavy question. And what I'll say is, clearly our COVID response got political. I don't know how politically correct that is to say it, but I said it. Whether it came to masking, vaccine mandates, in my personal opinion, we stepped a lot away from the science. And what I've been trying to preach is let the data speak for itself. Let the data speak for itself. And if we were upfront about some of this stuff, I do think we'd be in better position than we are today. And part of it was cancel culture. I'll be honest with you, every step, being a little bit, this mostly American audience, but in Canada, I do a lot of media, mainstream media. And every time I go on there, every time I put a tweet on or retweet something, everyone on this call on this panel could appreciate. There's that cancel culture. I'm a head of an ICU. I've gotten messages from staff and saying you got to be careful what you say. Even when you're using data-driven, when you're just responding to something that's data-driven. And so this is what takes courage. Everybody on this panel has stepped up, and I'll tell you, it's not easy, but it's for the kids. I've always made a personal stand that, there's only so much I could, there's only so much I could avoid, but when it came to standing up to our children, we have to do this. They can't speak for themselves. Someone has to speak up for them. And, this was a kind of a line in the sand for me. And so I think all of us need a bit to think of that courage. All of us can speak the language as we're doing today in data and presenting information and objectively and putting it hands into as many decision makers as possible. But right now, I'll tell you, the landscape is not fair, and it hasn't been this way. This isn't a consistent thing throughout time. If a paper said XYZ, we reported XYZ. I'll tell you, when it came to myocarditis evidence, so a lot of us saw the signal early on, and was like, I was nervous to bring it up. The Bangladesh mask studies, to say that some of the data supporting cloth masks might not be there. Whoa, are you going to be anti-mask or what have you? Or mentioning the harms of vaccine mandates, especially in marginalized community, BIPOC community, where there's already vaccine hesitancy. Oh, whoa, you're going to be anti-mask or whatever. Like, there's been so much dichotomy. It's like you're one way or another, and we just got to preach nuance. We got to be above it and say, like, you know what, you could call us what we want, but we're doing what we think is best for our kids. But to answer you directly, there's no easy way around this except for just lead by example.
Lucy, I want to add something to that. That was great, Kwadwo. And that something that has really given me like equipoise in this is like being sort of, from the Danish culture and considering from their perspective that, they have a multi-party system and they really encourage open debate about these topics that we've been discussing today, including vaccines and about masks. And so seeing there in Denmark and Norway and Sweden, and that the European CDC has never recommended masking for children under 12 because of their concerns about the effects on learning and social and emotional development, that has all along, made me pause and think, the groupthink is really strong in the US, and I can sort of step outside of that. And I think that, we would all do well to sort of, diversify the, who we're looking at and the data that we're looking at. And again, I think one of the things that the Scandinavian and European nations got right was that they encouraged more open debate about these issues, and there was less silencing.
I think it's a great point. And I think one of the main reasons we are sending our kids to school is to think critically and to make their own decision, use the facts and the data, and to figure out who they trust. What sources of information are they going to trust? How do they fact check their ideas, and then to come up with their own opinions, and to speak with their peers and their mentors with respect and humility, that just like we don't have the answers all tonight, like they don't have all the answers. I'm going to throw this over to Jean. As someone's asking here, as a parent, how do I respond to my children's school administrators when they say kids are building resiliency by mask wearing and quarantining? And what would I tell a child who's worried about bringing home the virus to their parent? And should we not be protecting children from the fear of sickening their loved one? Secondly, when will CDC and early childhood centers change guidelines to reflect the research that's coming out? My children's school is following guidelines that do not reduce quarantine time or masking. And I'll leave it there.
So we're getting a message there about difficulty with Jean's internet connection. So, well, one other question that I'll address kind of while we're waiting for Jean's internet to fix itself was around, kind of what about, unvaccinated kids under 5, and how should people, kind of think about that? Because obviously that's a topic that comes up a lot. A couple of things that points that I'll make there is one, again, for those kids, COVID does pose a flu-like risk. And so I start by anchoring yourself in that the flu is something you know how to deal with, right? And so you don't have to see COVID as something that's wildly different, even though it has a different name. The flu and other respiratory infections like RSV, pose very similar levels of risk to children. So you have the ability to draw on your own experience in grappling with that. The second thing I'll say is that, I think it's really important for us as scientists to draw the line between telling you what is true about the data and telling every single person what they should do, right? Because we may be experts in our various fields, but none of us is a moral expert around, given these facts, you should do this, or this amount of risk in your life is acceptable for this amount of reward. That's an individual choice that only you can make, right? So a lot of what we're advocating for here is that shift to put that power in individual families' hands, because what might be good for one family might be harmful for another family. And just treating everyone as if they're the same isn't acknowledging that reality.
Of kids being resilient, I think we can agree that the kids are resilient, but they're not resilient forever, and they aren't always resilient, and they have different vulnerabilities. I don't know, Jeff, do you want to take that about masking and
Yeah, I mean, I think the one thing that I can at least start with my own children is saying is that, there was aspects of, the whole concept of how quarantines work that did teach them to some degree how to take a new approach to life. And, there was aspects that I said, sometimes life throws you some curveballs and you have to know how to hit them. And that's fine in the short term. We all understand our kids should struggle at times in the short term and figure out how to get out of that and how to, navigate new ways when they do that. The long term is very different. We're in the long term now. We're 2 years in to our kids kind of having that understanding. And all of us that are pediatric providers are seeing it day in and day out with our patients, whether it's the ones I'm caring for in the inpatient world or the outpatient world. And so while I would agree that there's always some aspect of telling a child about how you navigate a difficult situation and helping them to get through that difficult situation, that's not endless. And that's something that we can't, take for granted and think that they are endlessly going to be able to be resilient with that, because they also have to forge new shared experiences.
Can I speak to this as well?
Go for it.
So I have teenagers, and I knew from the onset that when schools closed in March 2020, it was going to be a disaster for them. Teenagers developmentally are not supposed to be with their parents all the time. They are supposed to be with their friends. It is a really important part of their social and emotional development. And we live in a 2-parent household. We have a roof over our heads. We have enough resources to put food in the refrigerator. We have spotty internet. That's a whole different story. But my children withered being separated from their friends. And I actually weighed the risk of COVID in my then 14-year-old daughter versus the risk of her mental health. And I sent her twice on a plane and once on a train in the very beginning of the pandemic months, because the risk of her getting COVID was far less than the risk of serious harm to herself. And she needed to see her friends. And I actually had to send her out of town to do that. I am a volunteer physician at a YMCA camp in North Carolina. And we had a relatively normal session last summer. And it was shocking to me to watch the difference in the girls last summer compared to 2 summers prior when things really had been normal. A lot of the kids did fine. So we'll say the majority did fine. There was a very visible group, especially of younger children, who had been by their parents' side for 15 months. And even though they were outside in this gorgeous setting and they could run around and they could be mask free and they're surrounded by 600 other girls, they were timid. They had a hard time making those connections. They cried themselves to sleep because they missed their parents in ways that we haven't seen in prior years. Amongst the older girls, you could tell that they had spent most of the past year online, connecting via the anonymous virtual medium that is, and the way that they had been communicating with each other was very different from what it takes to communicate face to face. And so some of the older girls also had a harder time integrating in because they weren't sure how to communicate with their peers on that face-to-face level. We had more girls sent home for suicidal ideation that first week than we have in past years. And talking to the girls, I didn't honestly think that they were suicidal, but they had spent all of this time online dropping their little suicidal love notes, and to which they had gotten a lot of positive reinforcement. And it turns out when you say that in a room full of people, your 19-year-old counselors are crying themselves to sleep because they're not sure if you're serious or not. So there were a lot of adjustment issues to coming back to what should have been a very happy, normal experience for camp that I don't think that we should diminish or look away from.
If I could add to just the part about resiliency, that a lot of the conversation about resiliency landed in some of the pediatric studies that focused on ACEs, or adverse childhood experiences. And that was done out of an interest of understanding why certain people, when they had adverse childhood experiences, did better than others. That was never a thing you would lean on to say, I guess kids are going to be okay because they have resiliency, and maybe we can train them to be more resilient so they could tolerate more harm. And that part about being able to say that, the prior standards that we had leading into COVID about what things were right to do with kids and not, the burden of proof is shifted to having to prove that they're not harmed, rather than having to prove that the prior standard should have shifted. And I think that that's been a big part of, as an example, resiliency, where they're plastic, they're malleable, they'll pull their bootstraps up, and maybe, but that's not a bet I really like taking.
Thanks, Corey. I think we're going to wrap up now. I wanted to just first say thank you to all the participants, for everyone who joined us this evening for this really great discussion. I apologize to anybody whose questions we didn't get to answer. There are so many of you. I hope that we'll be able to engage with you in other ways. Most of us are on Twitter, and we certainly welcome feedback to the toolkit. We recognize that we are a group of 14 experts, scientists and physicians, and that we are doing the best job we can to present you with the most accurate data and to put a frame around the data so that you can bring to your community this information and a decision-making rubric you might use to benefit the kids in your community, to help them mentally and physically. We recognize the diversity of people's experiences. We recognize the toll on all of us in varying ways. We recognize the toll of the virus. We recognize the toll of the restrictions. We recognize with humility that we are only one group, and we respectfully submit our toolkit to you with the understanding that we want to work together. We are learning alongside you, and we hope this was helpful, and we hope that you will take this to your communities and share it widely. And please continue to give us feedback. We welcome it, as long as it's constructive and respectful. Then that's fantastic. And good night, everybody, and thank you for joining us.